We now shift away from looking at unemployment trends to workers on the front lines. In this section, we are going to ask which workers are on the front lines and what are the health risks of different types of occupations under this pandemic. A popular meme asserts that there wasn't really a lockdown, just, quote, rich people hiding while poor people brought them things. We're going to assess the extent to which this is a true claim by breaking down the data. The World Health Organization does describe a class disparity in workers who can work from home. The World Economic Forum does describe a class disparity in who can work from home as one of 4 major trends contributing to COVID inequality. In this quote, they make a distinction between high-paid workers working from home and blue-collar workers who tend not to have this option. So how does this break down in terms of income? Drawing on data from the U.S. Bureau of Labor Statistics, Nicole PANGBORN and Christopher Rhea show that there is a divide between people who can telework and those who cannot. One of the ways they break down this divide is by class. Occupations that are higher paying, like professional jobs and management level positions, tend to also be telecommuter friendly. In the US in 2019, these occupations had a median monthly earning of $5,236. On the other hand, occupations in the service industry, natural resources, construction, maintenance, childcare, and other service jobs tend to require a physical presence and have a median monthly earning between $2,368 and $3,476, substantially lower. So we do see that occupations with a lower wage attached tend to be less likely to accommodate working from home. We can also see that these occupations are gendered and in some cases racialized. In the US in 2019, men made up just under 95% of workers in natural resources, construction, and maintenance occupations. Men of color, especially Hispanic individuals, are overrepresented in these fields. On the flip side, low-wage face-to-face occupations related to childcare and health are female-dominated, with women of color overrepresented. Drawing on pre-COVID data from the Bureau of Labor Statistics, we can see that based on race, Asian and white workers are much more likely to be able to telework, and Black and Latinx workers are much less likely. These trends were in place before COVID-19 hit, but came to take on greater significance in this pandemic era. So we know that among employed workers, class, race, and gender partially explain which workers have to go into work under the pandemic and which workers can stay at home. But which of these frontline occupations increases a worker's likelihood of being exposed to COVID-19? Here, additional layers of inequality emerge. Let's revisit the trend identified by the World Economic Forum, that higher paid workers are working from home, while lower paid blue-collar workers typically do not have this option. But not all lower paid jobs are blue-collar. There's also pink-collar jobs, as we've discussed. And blue and pink-collar jobs tend to bring different COVID risks for the workers doing these jobs. Consider working in construction, a blue-collar job, versus being a cashier or a home health aide, a pink-collar job. All are considered essential work under the pandemic, but the cashier and home health aide have more interaction with the public. And the home health aide is likely most at risk because their interactions with the public, for example, elders, are in very close physical proximity. In 2020, Rhea and PANGBORN concluded that there is an overrepresentation of women and workers of color in essential occupations that involve, quote, close proximity to other people and high probabilities of exposure to the virus. In a quantitative analysis published in the Canadian Review of Sociology, Dr. St. Denis finds, quote, women work in occupations associated with a significantly higher average risk of exposure to COVID-19 than men. This is driven by their overrepresentation in high-risk, broad occupational categories such as health occupations. And many of these high-risk occupations are also low income. This is especially the case for women, immigrants, and members of visible minority groups. For example, some of the lower-paid occupations in the health field are nurse aides, patient services associates, and orderlies, meaning various types of medical assistants. These occupations are overwhelmingly filled by women, and some groups of women more than others. In Canada, this includes women of color and immigrant women. These occupations are also deemed essential under the pandemic, require close contact with vulnerable groups, and ultimately put workers at higher risk of contracting coronavirus. Statistics Canada in 2020 found that workers in these occupations were, quote, at a higher risk of contracting COVID-19, especially those working in long-term care facilities in the provinces of Quebec and Ontario. A number of workers in these occupations contracted the virus, which was an additional risk factor for their families and communities. In Canada, more than 1/3 of employees in these occupations are immigrants, even though, by comparison, immigrants represent less than 1/4 of people in all other occupations in the country. In this Statistics Canada table, we see a breakdown by year of the proportion of immigrants among nurse aides, orderlies, and patient services associates. What do you notice about this chart? First, the proportion of immigrants in these occupations is increasing at a higher rate than the proportion of immigrants in other occupations in Canada. In some of Canada's largest cities, including Toronto, Vancouver, and Calgary, over 70% of people in these occupations were immigrants. And the vast majority of immigrants in these occupations are immigrant women, usually over 80%. Among these women, Black and Filipino workers are highly overrepresented. And many of these immigrant workers have a university degree from another country that is not recognized in Canada. UBC professor Dr. Nora Angeles recently spoke to the Canadian Broadcasting Corporation about the disproportionate ways Filipino-Canadians are affected by the pandemic. As Filipino workers are overrepresented in health occupations, many work in long-term care homes and assisted living facilities, including those facilities that have faced staggering coronavirus outbreaks. And there are Canadian immigration and labor policies that Professor Angeles ties to this overrepresentation, including the Live-In Caregiver Program, which tends to keep many Filipino Canadians working in seniors care, domestic childcare, and other low-wage sectors. In about 50% of cases in the Live-In Caregiver Program, Dr. Angeles explains participants remain in caregiving work and at a similar wage value even 15 years after leaving the program. This is in a context where senior care services have been increasingly subcontracted to private care homes over the past 2 decades. Care workers in these facilities were already facing numerous challenges even before COVID hit. These challenges include low pay, increased workload, poor working conditions, and the use of part-time or casual rather than full-time and permanent labor. Workers who could only get part-time hours have therefore needed to work at numerous facilities to pay the bills. Under COVID-19, these challenging workplace conditions became the same conditions under which coronavirus could easily spread to both patients and care workers. In the British Columbia context, Provincial Health Officer Dr. Bonnie Henry implemented a single-site work order, meaning that healthcare aides could only work at one institution. While this was an effective measure in reducing viral spread, it drastically reduced the income of some healthcare aides, particularly those on casual and temporary contracts, who now could only obtain part-time hours from just one facility. This was partially alleviated by BC's temporary $4 an hour, 16-week pay boost for frontline workers. However, a more long-term measure would include the government developing pathways to recognize foreign credentials. As some of these immigrant care aides were nurses and doctors in their home countries,